to another episode of Rethink Healthcare. I'm Wendy Ball, and this is
Mr. Montenegro.
Mr. Montenegro made it again.
Yes, of course.
For another episode.
I love these episodes. Especially, you always talk about food, so.
I know. We're talking about our gut before and steaks, and now we're going to talk about not food.
Difficult things.
Difficult things.
Yes, I think there was a request to talk about difficult patients.
Difficult patients. You know, I used to say non-compliant, like my patient was non-compliant. I don't know that we're allowed to say that anymore, are we?
I mean, it is still an ICD-10 diagnosis.
Is it still an ICD-10 diagnosis?
Non-compliance, as far as I know.
Okay. I thought there was like kind of moving away from like, why are they non-compliant? Is really like sometimes your patient doesn't want to take the medications, not because they want to be difficult, but sometimes they don't want to take it because it hurts their stomach.
I mean, they always have a choice. It's
They
the
do.
patient's choice, and if they don't want to follow your advice,
They don't have to. They can
This
take it
is
or leave it.
Free
right?
will. It's free
Yeah.
will here.
Yeah.
So I guess we have to kind of define difficult patient first. You define non-compliance as part of having a difficult
Could be.
patient, but I mean, sometimes when you tell me difficult patient, I might think clinically it's a difficult clinical case where I have to really
Ooh.
figure out what's going on with them.
I like that.
So I think there's different definitions that we have to kind of dive into when it comes to difficult patients, or it could be difficult from a behavior perspective.
Yeah, we could go all different directions with this.
Yeah.
So let's start with the first one that you talked about it being a little more complex of a patient.
Yes. So how do we treat complex patients or difficult patients on that regard? I think my approach with that is collaborate.
Okay, I love that. Who
You know.
who are you going to collaborate with?
I mean, as
Who are
soon
you
as
going to call?
the Ghostbusters. No, it's really who's pertinent. I mean, as a nurse practitioner, I have a collaborating physician who I
Okay.
would be my first call. But if it's, let's say, it's a case where I may need to call on a different specialist, then you call on a different specialist, whether it be cardiologist or nephrologist. So it really depends on that specific point in time. I mean, as nurses, if you're faced with a patient that maybe a bit more, maybe above what you're comfortable with, right? So from a difficulty level, collaborate with your peers.
Yeah, I love that.
Yeah.
Always ask for another opinion,
Yes.
right? More eyes on a patient, more people kind of
Yeah.
coming in and collaborating together. We can come up with some maybe better solutions or ideas.
I mean, keep in mind the hierarchy as well. I mean, if you're in the healthcare system or some sort of system, there'll be some sort of supervisor somewhere there. So if you feel like, okay, you know what, this patient is a bit more complex than what I'm able to manage, reach out to the supervisor and says, hey, I need help here.
yeah.
And don't take that against you and says, okay, it's a lack of my knowledge base, which could be normal, but then also use that as the opportunity to then increase your knowledge base.
And I love nowadays we carry these like little computers in our hands. They're called
Yeah.
cell phones. And I know when we went to nursing school, we did not have these little computers. We had libraries and microfiche and
and
all that kind of stuff.
Thick books that you
Yes.
have to.
But you can look up information, and get knowledge and kind of dig into things also right at your fingertips. So that's a great thing to do with difficult patients. Now, have you ever had a difficult patient behaviorally?
Oh, yeah,
Okay, so
of course.
what in what context?
We talked about compliance before.
Okay.
They're not being compliant, let's say, in the wound care world, right? They're not being compliant with the treatments. Educate. I mean, if you're able to educate them and they're educatable, I mean, sometimes they're not. I mean, if they have Alzheimer's, dementia, then you may not be able to physically educate them in terms of those.
You can pull in their family, their caregivers,
Yes.
and those type of
Yeah.
resources to help and assist with that.
Yeah.
But how about a patient? Have you ever had a patient get mad at you, yell at you? I mean, I've been to the Walmart, I've been into all different kinds of stores. Driving around, people are yelling at each other. Have you ever had that instance where a patient just was not happy with you?
Yeah, they may not agree with my assessment, and they
Okay.
may not agree with the treatment plan that I intend to put them in, or maybe they're asking for certain things that I don't agree with.
Okay.
And in those cases, I usually would just stand my ground and says, no, clinically, this is what I see is happening,
Okay.
and you reason it out with them. But
Yeah.
again, it's a two-way street. You also have to come in from their angle and really find out, okay, well, why is it that they're asking for certain things? So,
Or why are they frustrated? Why are they upset?
Yeah.
Are they really upset with you? Are they trying to be difficult with you? Or is it just, they're away from their family. There's other
Yeah.
things going on. They're sick. They're not feeling
Yeah.
well. They don't know how to deal with the stress going on in their
Yeah.
lives. And us just coming back at them in a rough way is never going to help our patients. So, kind of figuring out that underlying cause.
it comes down to the communication, as you said
Yeah.
before. We talked about it in a prior episode. Is the communication aspect is very important in this case when you're dealing with difficult patients or difficult families.
Yes.
Really, a lot of times I find is just finding a way to empathetically communicate with them, and then from there things settle down. So usually, if I have a family who may want who tends to call a lot and stuff like that. What I would sometimes do is, I don't wait for them to call me. I would call them ahead of time.
Oh.
Say, here's what's happening. And usually, a lot of times when that happens, if I do that, I usually never hear from them again.
You're building that trust, finding that
Yeah.
common ground.
Yeah.
I love that. Now, I was out with students in clinical one time, and there was a nurse out caring for patients, and she was out in the hallway speaking to another patient, and that patient got a little aggressive with her, started yelling at her. And I love seeing this nurse respond, because she was starting to get upset, but she knew her limitations, and she stopped and she took a time out and she said, just give me a minute. And I loved that way of her just stepping back, getting her cool, because we're human beings too,
Yes,
right? We are
of
humans,
course.
and we have feelings and responses, and we are professional.
Yeah.
But sometimes, when a patient's yelling at you, or I've been called some names. So I've worked in the emergency room. I've worked in places where people are just, it happens. But I think stepping away and always keeping your professionalism is super important, and then come back with a fresh, way of thinking about it, or maybe even send somebody else in. So,
Yeah. If you feel like an assignment's not appropriate, but by all means, says, okay, what, can you give me a hand? Can we trade patients here? I've even had instances wherein I felt that the patient was trying to take advantage of my coworker, and but my coworker was too nice to really stand up for herself, and I told my coworker, you know what, let me take that patient. Let's switch. You don't have to take one of mine. Let me just take that. Let me help you out here.
I've even had a student that thought, or a patient was crossing like a sexual boundary with them, and they were just kind of flirting and a little inappropriate with this student. And I think that's where we need to have good boundaries. And we did move that assignment from that patient, and I did assign somebody else that was appropriate to care for that patient. So
yeah, but also in those instances, you have to tell the patient
Absolutely.
straight up, that's inappropriate, and that's not going to be tolerated.
that absolutely.
You have to be firm, and you got to set your boundaries too.
And I think, and I've told my students that if you set that boundary up, if a patient makes a sexual remark that, they're just making a joke, if you laugh at it, you're kind of, bringing that on yourself. So I think, just saying, and setting that boundary to begin with, that's not the kind of relationship we're going to have. We're going to have a professional nurse-patient relationship. So lots of different difficult patients here, from acuity of care to patients that just may be having a hard time with us.
Yeah, or behaviors, or maybe misinterpretation.
Yes,
so there, so all those could come into play. So you just have to kind of get to the bottom of it. Don't be afraid to really speak up whether you need to call for help, collaborate amongst, or just set the boundaries straight as well. So all those are certainly professional actions.
Okay, so if you've had any difficult patients, you can always let us know some of the experiences that you've had and how you've dealt with that. And this is another take. We'll see you next time on Rethink Healthcare.
Bye.